We now follow up with some cases, and it will be focused on hepatitis B and C. You've heard that over the years we have now got many new drugs for hepatitis C, and they really broadly belong to three different classes. One would be the protease inhibitors. The other one would be the NS5A inhibitors, and the third group are the polymerase inhibitors, and they're the NUs and the non-NUs. You can tell which group they belong to by looking at the last few alphabets of the name. So the protease inhibitors end with Previr, and the NS5A inhibitors Asvir, and the polymerase inhibitors is Bilvir, okay? Although the first protease inhibitors were only approved in 2011, some of them are already dead. You don't hear about boceprevir and telaprevir any longer. Cimeprevir, paritaprevir are no longer used. So you're really left with grazoprevir, vosiloprevir, which is the new combination, the triple combination, and glycopivir. And in NS5A inhibitors, you have ladipasvir, albasvir, valpatisvir, and pibrentasvir. Again, the initial Viekira pack, these two drugs are no longer used. And the clatasvir is also rarely used nowadays. The new polymerase inhibitor, sofosbuvir, is the backbone of the DAA combination. The non-nuke NS5B polymerase inhibitor, the sabavir, which was in the Viekira pack, again, is really no longer used. So you have this in your syllabus, and I'm not going to go through the details, but it really helps to summarize everything from the ASLD, IDSA guidance into tables. So these are the FDA-approved combination of HCV DAAs. Every patient knows Havoni because they watch TV, and that's sofosbuvir plus ladipasvir. So it's a nuke polymerase inhibitor plus NS5A inhibitor. It's not exactly pan-genotype because 2 and 3 doesn't actually work as well. And one of the problems is you shouldn't be using it in patients with advanced CKD. Epclusa, on the other hand, which is sofosbuvir plus valpatisvir, which is a newer NS5A inhibitor, is pan-genotypic because there's sofosbuvir, same limitation with renal dysfunction. Now, Sepatir is a different combination, and it consists of a protease inhibitor and an NS5A inhibitor. It's for genotypes 1 and 4 only. You can use it in patients with CKD and dialysis patients as well, but when you have a protease inhibitor, you cannot use it in decompensated cirrhosis. Now, Mevret, which is the GP combination, a new combination from AbbVie, which replaced the Viekira, that consists of the protease inhibitor, NS5A inhibitor, is pan-genotypic, and it can be used in patients with renal dysfunction, including dialysis. But again, because of protease inhibitor, you cannot use it in patients with decompensated cirrhosis. So another new combination is a triple combination. So this is Vosavir, and it consists of essentially Epclusa, sofosbuvir, valpatisvir, but you add on a protease inhibitor to make it a triple combination. This is pan-genotypic, again, because there's a protease inhibitor not for decompensated cirrhosis patients because of sofosbuvir, not for patients with GFR of less than 30. And the last combination we rarely ever use. So with all these different combinations, what do we do when we have patients? So the thing to really think about is, first, what is the genotype? And is this a treatment-naive or DAA-experienced patient? Does the patient have cirrhosis? And if the patient has cirrhosis, is it compensated cirrhosis or decompensated cirrhosis? You can see that here for genotype 1, if they have no cirrhosis or compensated cirrhosis and treatment-naive, you have a choice of multiple combination, and in general, it's roughly 12 weeks of treatment. In some cases, you can have 8 weeks, and with the Sepatir, which is the albasvir and grazoprevir, if they have genotype 1, you should be testing for resistance-associated mutations. If that is present, then it's a longer duration with ribavirin. Well, what about genotypes 2 and 3? If they're treatment naive, it's relatively simple. It's essentially you use Epclusa, which is sofosbuvir, valpatisvir, or methrit, which is the GP combination. Depending on whether they have cirrhosis or not, it's either 12 weeks here with Epclusa or with the GP combination, no cirrhosis, 8 weeks, cirrhosis, 12 weeks. But we're beginning now to see some DAA experience in patients who fail. Now, DAAs work very well, but we still have some failure. The problem is most of the failure occurs in decompensated cirrhotic patients. And right now, we really have very limited options. We do have options for patients with no cirrhosis or compensated cirrhosis. So for example, for genotype 1, we can use the triple combination for 12 weeks. We can use some GP for some of these patients. But the data on patients who have received an NS5A inhibitor is extremely limited, and you have to use it for longer. And we still are not sure exactly how effective that is. For genotype 1B, it's much easier. You have a choice of just retreating with Epclusa if they don't have cirrhosis, or with triple therapy if they have cirrhosis. For genotypes 2 and 3, there are very few failures, mostly the genotype 3 failures. And in the past, these patients would have only been treated mostly with sofosbuvir, ribavirin, or sofosbuvir plus daclatasvir. So for genotype 2, it's easy. If they fail with DAA, you can either use Epclusa or you can use the GP combination. For genotype 3, on the other hand, you likely are going to need to use the triple therapy combination, and if they have cirrhosis, possibly with combination of ribavirin. So we do have multiple combinations. And why do we have some treatment failure? And this is largely related to drug resistance mutations. Hepatitis C is an RNA-containing virus, and RNA replication has very high error rate. So even for patients who have not been exposed to any of these DAAs, they may already have baseline resistance-associated mutations, and with some combination, the baseline resistance mutations would impact the likelihood of response. Certainly in patients who fail to achieve SVR, and nowadays most of these patients do respond on treatment, it's when you stop that they relapse. And when they relapse and you test for resistance mutation, most often time you'll find those mutations present. How long do these mutations persist? It depends. Mutations to the protease inhibitor tend to go away after a few months. You stop treatment, it reverts back to the wild-type virus. On the other hand, resistance mutation to NS5A inhibitor can last for many years. So people who've been exposed to NS5A drugs and fail to respond, the retreatment becomes more difficult because these resistance mutations persist for a long time. Resistance to NS5A nukes, sofosbuvir, is extremely rare. And those mutations tend to impact the ability of the virus to replicate. That's the reason why sofosbuvir is such a strong backbone drug. So let's start with some cases. This, unfortunately, is the common Hep C patients that we see nowadays, not your 60-year-old diagnosed for the last 30 years, but recent diagnosis of Hep C. 32-year-old young guy, Hep C, genotype 1A, recently stopped using heroin injections. Currently on Suboxone, no other medications. He said that heroin is my drug of choice. I rarely ever drink. He was tested for HIV, that was negative. Surface antigen was negative. He had multiple risk factors, so he had also hepatitis B core antibody, and he was negative for surface antibody. His liver enzyme mildly elevated, normal synthetic function, HCV RNA 2.7 million international units per ml. And as Jessica mentioned, we don't do biopsies these days that often, particularly when we have a known diagnosis. So we did a fibroscan, and the liver stiffness measurement was 6.5 kilopascal, indicating that he had very mild fibrosis. So he was here to discuss some treatment options. And before we go to treatment options, what are the things that we need to think about? When we're thinking of treating this patient, obviously we're thinking, what's the chance of SVR? This guy just recently stopped using drugs. Is he going to be compliant with his medications? If we fight insurance and get him the treatment, is he going to take it? Is there concern about drug interactions with Suboxone? What's the risk of HCV reinfection? Maybe we're going to get a cure, and then he goes back to using drugs, and is he going to get reinfected again? And what's the risk of HBV reactivation because he's core antibody positive? So let's look at this. So he's genotype 1A, treatment naive, and the FibroScan says that he doesn't have cirrhosis. So what are his options? Well, his options are you can use Sepatier for 12 weeks if he doesn't have resistance-associated mutation. But if he does, then you need 16 weeks with ribavirin. Well, you can also use some GP, and it will be 8 weeks only. His viral load is actually less than 6 million, and he's HIV negative, he's white, he's not black. So we can also use Havoni for 8 weeks. Or we can use Epclusa for 12 weeks. Now, knowing that this is a young guy, recent diagnosis, recently stopped using drugs, I would prefer not to use ribavirin, and I would prefer the shortest duration of treatment because he's going to really need a lot of hand-holding to make sure that we get him through and finish the course of treatment. So the 8-week options are the most attractive in this particular case. Well, let's talk about treating hepatitis C patients with recent drug use. Dr. Fontana alluded to it. In patients that you carefully select. And this is the reason why I would never put these patients on treatment the first time I see them. I would order a bunch of tests, get them to come back. Some of them never show up for a follow-up visit. That's the end of the story. I can't help everyone. But if they show up, they show compliance, they follow instructions, and they are in a program, the data show that their chance of SPR is just as good as other patients. And there is no drug interactions with Suboxone or with methadone. Well, what's the risk of reinfection? Because we can't tell. This patient only just stopped using drugs 4 months ago, and we know that there's a very high relapse rate. So there are several studies. Actually, at the ASLD meeting this year, there were 2 studies, one looking at people who were on opiate agonist therapy, and they found that the reinfection rate was only 2.3 per 100 person years. And some of these had a transient infection, and persistent reinfection rate was 1.6 per 100 person years. Another study, this was an Australian study, and this was an American study. They actually found that there was no reinfection during 1 year follow-up, and you would say that, well, 1 year is still relatively short follow-up. And these were all patients who were attending a methadone clinic, so obviously there was a lot more supervision for those patients. So again, in carefully selected patients, we can achieve similar SVR with low reinfection rate. Now, Dr. Fontana mentioned about the risk of hepatitis B reactivation. So the current recommendation is we got to make sure that we test every patient for hepatitis B surface antigen and for hepatitis B core antibody before we start DAA therapy so that you know who you need to be watching out for and who you might need to consider prophylactic antiviral therapy. So there is one study presented actually at EASL, not at ASLD meeting, conducted in Taiwan, where they treated 111 patients with hepatitis C and who also had hepatitis B co-infection. These were all surface antigen positive. Now, it depends on when we talk about hepatitis B reactivation. It depends on whether we're thinking of just a bump in HBV DNA but with no noticeable ALT increase, or a more severe reactivation where you actually see an ALT increase. And they found that if you prospectively follow these patients and you check baseline HBV DNA and you monitor HBV DNA after the start of DAA therapy, actually a bump in HBV DNA is very common. A third of these patients, actually 2/3 of these patients, had a greater than 1 log increase in HBV DNA during DAA therapy. But only a few patients had increase in ALT. So in retrospective studies, you find that reactivation is uncommon because you can only detect when the ALT goes up. So in this study, even though 70 patients had increase in HBV DNA, only 5 had ALT more than 2 times upper limit of normal, and none of them actually had increase in bilirubin or liver failure because they were watching the patients, and they had 2 patients started antiviral therapy. Now, in our particular patient, this patient was surface antigen negative and core antibody positive, and they found 3 patients with increase in ALT, but none of them was related to HBV reactivation because there was no reappearance of surface antigen or HBV DNA. So I agree with Dr. Fontana that in surface antigen negative core antibody positive patients, the risk is extremely low, and we actually don't monitor the HBV DNA, we monitor ALT. You put them on DAA, you expect the ALT to improve. If it doesn't improve, but instead it goes up, that's when you need to be thinking of checking for hepatitis B. But for surface antigen positive patients, the risk is higher, and we need to be watching more closely, monitor HBV DNA, and if necessary, put them on antiviral. So this is how I would propose. This is sort of hepatitis B reactivation. The virus reactivating is common, but hepatitis flare is extremely rare. Test every patient. And if they're HBs antigen positive at baseline, test HBV DNA as well. And if they meet criteria for hepatitis B treatment, because the ALT is up, the DNA is high, treat them. Otherwise, you should be monitoring them very closely. And for the surface antigen negative core antibody positive patients, risk of reactivation is extremely rare. Monitor them with ALT. If the DNA, ALT doesn't go down but goes up, you should be checking for hepatitis B markers. So let's move on to the second patient. So this is a 58-year-old male, hepatitis C, also genotype 1A. But this is different. This patient has compensated cirrhosis. This patient had been treated in 2015 with Havoni, 12 weeks of sofosbuvir and ledipasvir, and he had on-treatment response, but relapsed when treatment was stopped. And he's back in 2017. He said, I heard that there are other newer drugs. Can I be retreated? So at this stage, fortunately for him, he's still compensated. His child Turco-Pugh score is 6, his MEL score is 10, his renal function is slightly impaired, but still reasonably good at 46. So what should we do? Well, he's been exposed to a polymerase inhibitor and an NS5A inhibitor. We can certainly, ideally, I would treat him with a triple therapy, sort of slam him with as much drugs as I can. There's some data to suggest that maybe GP would work, although there's very limited data. So what are the recommendations? These are the recommendations: genotype 1A, compensated cirrhosis. He had been exposed, the virus has been exposed to NS5A inhibitor. The data suggests that we can give him the triple therapy for 12 weeks. If we were to give him the GP, we'll have to consider 16 weeks of treatment, but bear in mind the data is very limited. And let me share with you some of the data. So this is the Polaris-1 study in patients who had been treated with DAA that contained NS5A. And when you retreat them with the triple therapy for 12 weeks, overall the SVR rate was pretty good, 90-odd%. But you see that there is a slightly lower SVR rate with genotype 1A, and certainly with genotype 3 patients, and that's where most of the treatment failure occur. Genotype 4, that was actually a very small number of patients. So overall, the triple therapy worked quite well. This is consistently 95%, 97% SVR rate, and this is the reason why this is recommended. But what about, what if we were to use GP? Well, the data is impressive, but the number is extremely small. In NS5A inhibitor experienced patient, which is what this patient has, the data was based on 17 patients only. So 17 patients treated with 16 weeks, and yes, there was a 94% SVR rate, but it's a very small number of patients. Now, it's a lot easier if the patients have not been exposed to NS5A. So here is a somewhat different group of patients. These were patients who have been treated with DAA but not NS5A. And if you give them either a triple therapy, so fosbuvir, valpatisvir, and voxilaprevir, the triple therapy with Vosavir, or Epclusa, you find that in patients who received the triple therapy, the SVR rate overall was much better. And this is a study which included a sizable number of genotype 3 patients. And again, what you see is that if they had DAA failure and you're giving them 2 drugs, in genotype 1A and genotype 3 patients, the SVR rate is lower. So for DAA failures in general, I think that we should be going for the triple therapy if we can get access. So it's good that we now have some rescue therapy for DAA failure patients, and we're able to consistently achieve 95% SVR in patients with NS5A inhibitor or NS3 protease inhibitor experienced patients. But if a patient had been exposed to both NS5A inhibitor as well as protease inhibitor, then the chances are really not good because the virus might already have resistance to 2 classes of drugs, making it very difficult. But we have to bear in mind that we still have somewhat lower rate of response in patients with genotype 1A or 3, and there are limited data in patients with cirrhosis, particularly if they have been exposed to both NS5A and NS3. And because Vosavir, the triple therapy regimen, contains a protease inhibitor, and a GP regimen also contains a protease inhibitor, unfortunately, they're not approved for your child's BC cirrhotic patients. This, unfortunately, is the largest group of patients with DAA failure. The DAA failures are not your F0, F1 patient. The DAA failures are your decompensated cirrhotic patients. Unfortunately, none of these new combination is approved for patients with decompensated cirrhosis. So we still need to find rescue therapy for those patients who come with decompensation. And of these 2 new combinations, Methred, which is the GP regimen, is approved for CKD 4 and 5, whereas Vosavir is not approved for patients with GFR of less than 30. And the role of baseline testing for resistance-associated substitutions is unclear at this stage. There's no clear-cut guideline that if you find resistance-associated substitution, the treatment would definitely fail because we have some patients who still respond. So this is still a matter of research. So now I'm going to move and present a case of hepatitis B. With hepatitis B, when to start treatment is still sort of an art and not a science. With Hep C, we say the treatment is so good, treat everyone unless you predict that this patient is going to die within a year and from non-liver related cause because it's simple and the efficacy is very high. With hepatitis B, we say if the patient comes to you with cirrhosis, whether it's compensated or decompensated, with detectable HBV DNA, put them on treatment, suppress the virus, suppress the inflammation, slows down disease progression, reduce the risk of liver cancer. The big debate is obviously in the patients who don't have cirrhosis, and currently our recommendation is we treat the patients with active disease. So these are the antigen-positive patients with high DNA and elevated liver enzymes, or the antigen-negative patients with high DNA and elevated liver enzymes. But we're not recommending treatment of patients in the immune-tolerant phase, antigen-positive, high DNA but normal liver enzymes, or those who are in the inactive carrier phase, antigen-negative, low DNA, and normal liver enzymes. The exception in terms of treatment in the immune-tolerant phase would be someone who's pregnant, a woman who's pregnant, who is antigen-positive, very high DNA, more than 200,000 international units per ml. Right now, we do recommend, in addition to giving the baby hepatitis B immune globulin and hepatitis B vaccine, we should be giving antiviral therapy because despite passive active prophylaxis, there's still a 6 to 10% chance that a baby is going to get infected, so we want to eliminate that. And the antiviral that we recommend is tenofovir. Breastfeeding is not contraindicated, and there's no reason to perform C-section just to reduce the risk of mother-to-child transmission. So as I've mentioned, for non-cirrhotics, we recommend treatment for e-antigen positive or e-antigen negative immune-active patients. The big debate when you're using the oral antiviral, the NUCs, is when to stop treatment. And there's really no clear-cut guideline, and this is the reason why Hep B treatment is so difficult. Because if it's just a matter of 8 weeks or 12 weeks, it's easy. Treat everyone, then you're done. But here you're committing many patients to many years or lifelong treatment. So for e-antigen positive patients, the non-cirrhotics, we said you may consider stopping treatment after the patient achieves E seroconversion. E-antigen goes from positive to negative, E-antibody becomes detectable. Additional 12 months of consolidation therapy, and then you can consider stopping. For cirrhosis patients, indefinite treatment. For e-antigen negative patients, for non-cirrhotic, it's either indefinite treatment or until S antigen loss. Whereas for cirrhotic patients, again, we say indefinite treatment. So for many of these patients, we're really talking about long-term, lifelong treatment. So let's now talk about a patient. This is a 50-year-old female, new diagnosis of ulcerative colitis, and not respond to the first line simple therapy, and the gastroenterologist said, well, we're going to start you on anti-TNF. And you know that before you start patients on anti-TNF, you've got to really screen them for a bunch of infections. This patient was tested for hepatitis B, surface antigen negative, core antibody positive, but surface antibody negative. The patient had TB and HIV testing, and they were both negative. So the first thing that you ask yourself is, what's the explanation of this hepatitis B serologic profile? How can this patient have isolated core antibody? No surface antigen, no surface antibody. And you also ask yourself, should this patient be vaccinated against hepatitis B? Because this patient is surface antibody negative. What's the risk of transmitting hepatitis B? Is this patient at risk of XEC? Is prophylactic HBV antiviral indicated because this patient is going to be starting on anti-TNF? So first, why would we have isolated core antibody? We know that if someone is chronically infected with hepatitis B, there will be core antibody positive, but there will also be surface antigen positive. If someone has serologically recovered from hepatitis B, there will be core antibody positive, but there will also be surface antibody positive. So what is going on? Well, the most common scenario is that this is someone with past chronic hepatitis B who has been surface antigen positive and core antibody positive for many, many years, but now with spontaneous loss of surface antigen. This is particularly true if this is someone who have been born in endemic areas or with risk factors for hepatitis B. They have risk behaviors, or they're HIV or Hep C positive. So we see this scenario in a lot of our Hep C patients. The other scenarios would be someone who's recovered from hepatitis B, a very transient Hep B infection, initially core antibody positive and surface antibody positive, but over time the surface antibody had become undetectable. This might be false positive core antibody reaction. No assay is perfect. It may be that this patient is in the window phase of acute hepatitis B, in which case this patient should be IgM core antibody positive. This is actually unlikely because catching people in the window phase is not common. You could sometimes tease this out by offering 1 dose of hepatitis B vaccine. Because if you offer 1 dose of hepatitis B vaccine, this situation, you get an immunistic response. 1 dose of vaccine, you get a boost of surface antibody. You get someone who had a past chronic infection, you're not going to get a response to hepatitis B vaccine. Someone with a false positive reaction, you would actually get a slow response to hepatitis B vaccine. So it's one way of teasing it out. You can test these patients for HBV DNA. Usually it's not detectable in the blood, but would be detectable in the liver. So what are the potential clinical implications when you find this scenario? In general, antiviral treatment is not necessary because most of these people are HBV DNA undetectable in the serum. You can try vaccine, as I've mentioned, to tease it out. The majority of these patients, they don't respond to vaccine or they don't need the vaccine. Some of them may have underlying liver damage if they had indeed chronic Hep B infection for many years before they clear surface antigen. And there is a persistent risk of hepatocellular carcinoma if indeed they had chronic Hep B infection for 45 years before this patient became surface antigen negative. But if they had a transient acute B with serological recovery and they were someone who lost the surface antibody, then the risk of hepatocellular carcinoma is extremely low. The reason why we pay attention to this scenario is usually concerns about reactivation when these patients are exposed to immunosuppressive drug, particularly with rituximab, as Dr. Fontana mentioned earlier. So the AASLD has updated the guidelines, but the guidance, which is covering all the other aspects that are not included in the 2015-2016 update, is coming out in 2018. And here we recommend for patients requiring immunosuppressive therapy that all of them get tested for surface antigen and core antibody. And if they're surface antigen positive, we recommend prophylactic antiviral therapy. On the other hand, if they're surface antigen negative, core antibody positive, they can be carefully monitored without necessarily starting everyone on prophylactic antiviral therapy, except for very potent immunosuppression like anti-CD20, rituximab. There, even for surface antigen negative, core antibody positive, there's a 20-30% chance of reactivation, so prophylactic antiviral is necessary. And certainly someone with leukemia, lymphoma, getting massive chemotherapy in preparation for stem cell transplant, prophylactic antiviral therapy is warranted. So this is a table that Dr. DiBiscelli and myself put together in a paper in Hepatology a few years ago. We tried to sort of arbitrarily classify the risk of reactivation based on the hepatitis B serology as well as the type of treatment. Anti-CD20 stem cell transplant, very high risk in surface antigen positive, moderate risk in surface antigen negative, core antibody positive, high dose steroid, high risk here, low risk here. So other therapies without concomitant steroids. Combination cytotoxic chemotherapy, moderate risk, low risk. Anti-TNF in this case, moderate risk, rare. However, this is in the absence of concomitant steroid. And if your patient needs steroid plus anti-TNF, then all of a sudden this risk becomes increased. Now, many of you read the AGA guidelines. Unfortunately, AGA guidelines I totally disagree with on this aspect because they consider anti-TNF in surface antigen negative core antibody positive patients as moderate risk and recommend prophylactic antiviral. There are multiple studies since the guidelines showing that the risk is low unless they have anti-TNF plus high-dose steroid plus other immunosuppressive therapy. And this is some data from one study that I've been working with using a Kaiser database. They had patients on anti-TNF for a median of 41 months. Reactivation in surface antigen positive patients were very high if they did not receive prophylactic antiviral, 9 out of 23. So you should prophylax these patients. On the other hand, they had 178 surface antigen negative core antibody positive patients, and none of the patients had reactivation. Now, this is a retrospective study, so we did not have serial HBV DNA monitoring, but this was based on ALT. None of them really had a substantial increase in ALT that make us concerned. And so for those reasons, I now recommend that for anti-TNF, in the absence of high-dose concomitant steroid, other immunosuppressive therapy, surface antigen negative, core antibody positive, we can monitor and not necessarily give prophylactic antiviral to everyone. So back to this patient, I've concluded that we'll be carefully monitoring this patient and not necessarily need prophylactic antiviral therapy.